And welcome back. Now, amid concern that COVID-19 vaccinations in South Africa are not going according to the set targets, the higher education and training sector is once again calling on students to get vaccinated. Now, this as some universities have been contemplating mandatory vaccination for both staff and students, and that those not vaccinated must undergo weekly testing at their own cost. Now, for more on this, we're joined by Professor Ramneek Ahluwalia, the CEO of Higher Health. Professor Ahluwalia, good morning. Thanks so much for speaking to us.
No, good morning to Sakani, and it's an absolute honor. Thank you.
Professor, I want to start by just taking a look at the ethics around this particular matter, because we started out with the president, no less, saying that nobody will be forced to vaccinate. And now we're at a point where we see not only institutions of higher learning, although that's our focus this morning, but in other spaces in society as well, where there seems to be a drive to, and you can't even call it coerce, because if you're saying it's going to be mandatory, there's no coercion there. It's simply, being rammed down people's throats. So let's talk about the ethics of that in the higher education space.
So you're absolutely right. We're dealing with a fatal, notifiable public health disease called COVID-19, highly transmissible, spreads very quickly, and is proven to be now fatal. It's killed people, and we've seen it reality. So when you are dealing with an occupational health risk, where there is a time where people who are going to be vaccinated have to be now mixed with people who are going to be non-vaccinated. And it becomes far more challenging when you are in a congregate setting. When you're talking about congregation means you're talking about students living in residences, in classrooms coming together, staff members interacting with the students, because that's what contact learning is about. And I think that these challenging questions, and when the science has started now clarifying and clearing that once you are vaccinated, because what the vaccine will do is it will increase your human immunity to a level that even if the virus enters your body, your viral load can be overcome very quickly, because your own immune system will overcome the virus, which means that not only you are less risk to death, but you're also less likely to transmit the virus to the other person. And then when you have this science, and when you have an occupational health safety act in place, and then you also have what we call the constitutional rights, which is freedom of speech, freedom of human body integrity or religion, which are section 12.1 or section 10. Then you start looking at what are the limitations on those constitutional rights, because the Constitution also allows a disease like this, an occupational health risk, giving chances to the employer to safeguard its employees, because it's also the responsibility of an employer. But again, the question about mandatory vaccination at this stage, again, is a bit too early again for the higher education. And again, it's 1.5 months to what we have opened our vaccination to a population above 18. Still early. People are making time. We need to put those efforts still further, which comes into the reality of how we can still promote vaccination. That's exactly we are emphasizing. But even if we have to go on to, we don't call it mandatory as a word, called regulations on vaccination, then it has to be thoughtfully put in a very phased approach. Who is more at risk? For example, students in Faculty of Health Sciences. Predominantly why? Because they themselves can carry the virus and give it to the patients. Patients are extremely vulnerable. Patients can die because of the student risk, or vice versa. And similarly, then campuses with residences, so that living together. So I think there has to be regulations which will come at a stage when our maturity of vaccination program will grow gradually. At this moment, the data is worrying for us. We've only seen 1/3 of our students vaccinated. Those are 1/3 students who believed in vaccination, even stood in long queues when vaccines were brought into our campuses. So 1/3 of our population is vaccinated in higher education, if at least partially vaccinated and waiting for the second dose. The challenge now is the middle 1/3 and the last 1/3. The last 1/3 is the one which has made their decision and they're not budging down, but the middle 1/3 are still wanting to and it's taking time. And that is the population that we are working, and the strategy is to push that middle one-third now. Because the middle one-third has made their mind, they start believing in science. They are not as influenced by the anti-vaxxers. They want some questions of answers like, our testicles increase? Whether we will have something called impotence. We will not be able to reproduce. And these are genuine questions. And interaction, bring science to them, peer-to-peer. And that is exactly where we are. And through you, we are appealing to this middle one-third to come in, also to the last one-third. And when we reach that two-third of our population, and that is a decision we need to make, whether the last one-third will still get influenced by the bigger peers, or will we have no choice then to start looking at those regulations?
So speaking to that middle third who aren't necessarily against vaccination, but they do have some hesitancy based on a lack of information, or are approaching a wait-and-see approach for some of the reasons that you've just mentioned, Professor Ahluwalia. Is enough being done? Is there enough information being shared with that group in order to make sure that they do receive at least some of the information that is causing the hesitancy at the moment?
You're absolutely right, Sakani. We are fighting another world called social media, and people who just believe in writing what they feel like. And it's a freedom of thought, so anybody can do. And that influences. So as much as you put as many efforts, they will always be diluted by a very strong social media presence. I always believe technology was invented for human advancements, but sometimes technology can be anti us. And that's another debate of a massive challenge we are fighting, irrespective of the number of resources. So what we've started is campaigns, campaigns on bringing vaccination on the campuses, specifically our rural and peri-urban areas where we can't build vaccination sites into the system. And we've got about over 1,000 sites that we can bring easy access of vaccination on the sites, But the campaign is more around health and wellness. We do not want to forget our population on HIV and TBs and other pandemics like mental health and gender-based violence. So destigmatizing COVID while bringing it under the health and wellness umbrella. Peer-to-peer is our biggest hope. We have foot soldiers. We're just praying our foot soldiers. This model works for us. It worked for HIV. It worked when our COVID-19 outbreaks were happening. We had to test them in large numbers and isolate them. It did work. But we are still battling. Will this be a powerful tool to change the mind of getting the vaccine, which is a jab in your arm? And that is there. And the last part we've done is we started taking doctors in the ICUs with us to the hospital. It's a great idea. They tell them the reality of medical science and what's happening in the hospital. Or how many young people are actually dying outside in the hospitals because not just a disease now left for only old people as it was always considered to be. We have seen fatalities, and we're seeing fatalities as the new mutants show affinity to young people. So I think there are many strategies that are being put, but our fight against that social media, the anti-vaxxers, is enormous. It's ginormous. We just are struggling at every bit of things that we try to move in.
And of course, the rights issue is coming to the fore very strongly, Professor Ahluwalia. You have yesterday the WITS SRC rejecting the proposal that was put on the table by that institution. You have at the University of Cape Town the Senate voting in favor of mandatory vaccination. It still has to go to council, of course, but you have Solidarity, for example, youth threatening legal action, saying that, their rights are being taken away, their rights are being eroded, the right to an education. So what's your view on that? I know you said at the beginning that perhaps it's a bit early to try and enforce mandatory vaccination. But generally, the way in which institutions of higher learning have approached this matter, what's your take on it, specifically with relation to the rights of students to an education and the right to choice?
So you're absolutely right. For higher health perspective, we have already started consultations in provinces. going to provinces and engaging various different sections, right from student unions to student formulations to even employee unions, and even including management, and understanding right at the levels of what is the challenges and what are the uniqueness of why mandatory now or later or when, and the consultation. So the reason the word is consultations, because at this moment, consulting populations which matter to in higher education is very, very relevant for a topic which is as debatable and as challenging it is. Universities debating at this moment, or getting it, some of the universities, each university is guided by a Higher Education Act, which gives them autonomy to make decisions as an employer. And that is why I started with the occupational health risk, and being a notifiable and such a highly transmissible disease, it helps them to make such decisions by themselves. But the question and advice will always be is, before any university makes any decision of this kind, a proper consultation with right till the bottom to understand the environment they are in. Each university is very unique at this moment. And each university has to look at its uniqueness of why it has to take a decision of that kind and how quickly it has to take a decision of that kind. A university which is very much like a medical-centered university or highly will probably have to take a decision due to the occupational health risk, or a university totally dependent on campus residences or people living in residences might have to go into that decision far quicker, versus TVETs or universities that have more abilities to take time towards vaccination maturity of it. So at this moment, we advise consultation. We still believe it's early stages. We still believe we need to get this second middle 1/3. We got the 1/3, which is a great achievement. We now, if we put a strong peer-to-peer, a strong vaccine promotion program, try them to convert the middle 1/3. They believe in the vaccine. These are just the questions that a little bit of science that will clarify them. We can get to 2/3 very quickly. There's no word now called herd immunity anymore because the virus mutates, but what we can achieve with the 2/3 is definitely to tame this virus very low, which means the virus will not be transmitting to the level the way it was. The virus will definitely not be killing the way it is, and the virus will be tamed down to the level we want. And then we will have that last 1/3 cohort, and then the science will probably give us more understanding. Can we live with the 2/3 versus 1/3, or do we need to go with a faster or regulatory methodologies? But there are certain areas in higher education which, for example, the faculties of health sciences, residences, and people with comorbidities, where certain regulations will play a role, but at a certain time. Still a bit early, but consultation is the right time to do.
So with regard to something such as reproductive health that you touched on earlier as well, is there enough evidence for you to satisfactorily answer the questions that students may have around this, that their reproductive systems won't be adversely impacted in the long run, for example?
We haven't seen any data so far. And I think we need to believe in what 3 billion people in the world have been vaccinated so far. There's a lot of data from 3 billion people. And when you're talking about a population of that kind, you have a very scientific evidence of what is the side effect to what is not the side effect. And then it gives empowerment to health professionals, to scientists, and more than that, the leadership in any sphere to make them give that reality in front. And that is exactly the reality. There is no study or there's no data coming from 3 billion people all over the world on anything to relate to impotence or sexual reproductivity or anything related to it. Any person by itself can attain any disease. I'm talking to you, Sakani. I might be suffering from an underlying disease, but it has nothing to do with the vaccination. It has nothing to do with COVID-19 jab that I have taken. It is just there in my body. I have to suffer with it, or I have to find a medical treatment to cure it. There's no interconnection or interconnectivity into that. So if a very few isolated cases, which are in few, say, numbers of counting, and say 10 or 12 people reported such thing all over the world out of 3 billion, there was still no correlation with the jab in that regard. So all we're trying to preach through peer-to-peer is, when you're talking about science, when you're talking about data, and when you're talking about 3 billion people evidence, then there is some meaning to why a vaccine will outweigh a far bigger risk of death versus a smaller or other small side effects like pain in your arm. There will be a lump in the arm, and there will be slight fever that can happen, which is normal on getting a vaccine, because your immune system gets responding to something that you have inoculated. But these are two small things to worry about in a bigger picture that saves life.
And just a final question, Professor Ahluwalia, with regard to incentives for students. What are your views on that? Would that perhaps be one of the things to look at, to incentivize students one way or another? What do you think of that?
I've been somebody who's been always against incentives when it comes to health. We had the same challenges with HIV in the past. We still have challenges with HIV. And through you, I still want to reinform South Africa. Don't forget, we have young pandemics of people being killed as young with pandemics like HIV and TBs and gender-based violence and teenage pregnancies. So we should not forget when COVID is all the attention it takes. But coming to your question, Sakani, is incentives now when such a notifiable disease has come in picture, and it's such a fatal disease eventually, COVID-19, the way it spreads. And now we're seeing that middle 1/3 where we can get it to the 2/3 of our population very quickly, because we've just done the 1/3, and we've seen a great evidence of 1/3 taking and standing in queues and getting vaccinated. Now we know this middle 1/3 is right there, and we just need to get it. And if incentives can do it, and soft incentives, why not? So as even myself changing to say yes, and we are deploying it. We are finding mechanisms with academics right now. Is there a soft incentivization from the academic sense? Can data be one of the incentivization? We are giving possible food parcels. We've done that, and we're already doing it. So I am in favor. I think sports, other small incentives, which matters in academia a lot, can play a role in saving another 1/3 of a population very quickly. Why not? We'll go for it.
Well, we'll have to leave it there. Thank you so much for your time this morning. And that was Professor Ramneek Ahluwalia, CEO of Higher Health, talking to us about health measures being taken by post-schooling education and training sector to encourage more individuals to get vaccinated. And with that, at 7 o'clock, time for the latest news with Leanne.